describe this? The lucent opaque or mixed. Is it well-defined, ill-defined? It's well-defined, and it has a radiolucent rim and a sclerotic border. Did you notice all of that? Did you notice its relationship to normal structures? It obscures the root apex of tooth number 19. All of those things together in a 20-year-old point to one thing, which is cementoblastoma.
Cementoblastoma.
Questions 2 and 3. Our 35-year-old with gradually increasing jaw swelling. Two tumors should be included at the top of your differential diagnosis. How would you describe the lesion? Lucent, opaque, or mixed? Lucent. Multilocular or unilocular? Multilocular. What is its location? Posterior mandible. Okay, so what are good diagnoses for a multilocular lucency in the posterior mandible as an adult? Conventional ameloblastoma, you always have to specify the type of ameloblastoma because conventional peripheral cystic ameloblastoma are actual diagnostic types.
No.
No.
Specified as
Have to specify.
I think I got 1 point.
So conventional ameloblastoma
You beat me,
is
bro.
the
I got
classic answer for this. What's another good answer? Adenogenic myxoma. Those are the two best. And other answers will be considered individually based on it.
Oh, the spelling?
You put both answers for 2 and a blank for 3. We'll figure that out. We'll figure that out. That's not a problem. We're pretty smart. We can figure that out.
So the question specifically asks for tumors, but I will review.
Adenogenic keratocyst is not considered to be a tumor. It is. Number 4. This is a patient who has had a recent temporary filling, returns with throbbing pain. There's slight local swelling, and you see a lesion. How would you describe the radiographic lesion associated with the tooth? Lucent, opaque, or mixed? It's lucent. What happened to the lamina dura at the apex? It's gone. So this kind of flares the lamina dura and the PDL and the root end. So when we put our clinical and radiographic features together, what's the best diagnosis? It's a dental abscess. This is a dental abscess. Acute apical periodontitis
Nice, bro.
will not have swelling and will have at most slight a larger identifiable apical lucency and swelling, so that means it has to be a dental abscess. Question?
I forgot about the pain part.
Too big of a radiographic lesion, and because swelling is present. So we have multiple pieces of information that we have to account for in our diagnosis question. But parulus is something that we see clinically in the mouth, not radiographically. It's that collection of exudate under the surface.
Odontoma
We
myxoma.
don't have a picture clinically, we have a radiographic lesion. So the patient may have a parulus, but if we don't see the parulus, we cannot make that diagnosis. It doesn't matter what it says.
I'm just ready for the
That's
weekend, bro.
clinical intraoral lesion. You can't diagnose it unless you see the clinical. Last question, then we move on. I think there might be some condensing osteitis around that, but that's normally asymptomatic. That does not account for the throbbing pain, the local swelling, and the radiolucency. So that would not be the primary diagnosis. But I might give you half credit for recognizing that that's there because I think there is some. All right. What do we see radiographically in this patient? Lucent, opaque, or mixed? It's a mixed lesion. Do you notice anything else about that mixed lesion? It has distinct tooth-like structures. It's well-defined, the new tooth-like structure. So there's really only one best diagnosis, and that is Compound odontoma. Compound means multiple.
Well, it makes sense now.
All right, number 6. What do we see radiographically? Is it loose and opaque or mixed? Is it multilocular or unilocular? Unilocular. What is its relationship to normal structures? Surrounding the crown of an unerected tooth and attaching the cemento-enamel junction, it can only be one thing as our top choice, the tibial cyst. Could
The one
it
you told me
actually
to
be something
remember.
else? Yes, but by far and away, the tibial cyst is the most likely and most common thing that presents. Number 7. Large caries. Young patient presents with this lesion associated with tooth number 3.
But you got this one for sure.
Chronic hyperplastic pulpitis.
You got this one?
Yeah, 3 points.
What if you touch it? What if you poke that with Tooth Explorer? They won't feel anything because there are no nerves in it because it's granulation tissue. But it is alive. It's not normal. Number 8. How would you describe this lesion? Lucent, opaque, or mixed? Lucent. Unilocular, multilocular? Unilocular, well-defined. Do you notice it's corrugated a little bit? Might be beginning to get some secondary loculations too. But anyway, teeth are vital next to it. What's the single best diagnosis? Lateral periodontal cyst. And why does that rise to the top? Because this is an adult and it's in that mandibular bicuspid location. That location is very specific for this disease. So that makes this diagnosis absolutely the best. Question. Why is it not radicular cyst? Because the teeth are vital.
What was it?
And radicular cyst is only
Lateral
exclusively
periodontal cyst.
associated with teeth with pride. Number 9. 8-year-old incidental finding. What is an incidental finding?
By spontaneously.
It wasn't what you were looking for when you did the exam, but you found it there. Sometimes those incidental findings are more significant than what you were looking for. But it was an unexpected finding. How would you describe this lesion? Lucent, opaque, or mixed? It's mixed to mostly opaque. Well-defined, ill-defined. Corticated, non-corticated border. Corticated and a radiolucent rim. What is its relationship to normal structures? It's obstructing the path of eruption of a permanent molar. Did you notice that? Yeah, that's kind of a hint too. What's the single best diagnosis? Complex odontoma. Good job.
Complex
And question
odontoma.
number 10, last but not least, what is the most common site of occurrence of the gingival cyst of the adult? It is mandibular bicuspid area, gingiva. Gingival attached gingiva. I don't know how specific you want that.
Not specific, please.
She will consider your answers individually. How is that? Okay. One last thing real quick before Dr. Grandi goes, because she needs this information too. We have a confirmed final exam schedule. I will post this. This is from Academic Affairs. It is your whole week final exam schedule. Because we have all kinds of interesting scheduling adventures this year. So
Wednesday.
the final examination for this course is Thursday of finals week, and that will not change.
Thursday.
And it is unfortunately in this room because that is the only room available on campus. Yes, we don't have a choice, and I don't like that either. We might come in and play with the room to spread out, get a little extra space here and there, but I might do that myself personally. But this is your final exam schedule, okay? I know that
Get out of here for 10.
Let's get out of here in an hour at most.
And I have something that is important that I would like to talk to you about while I'm pulling up now. So you were really not excused for a break. And I would appreciate it if you hung around. I did receive an email petitioning that we keep the exam on Monday because you all plan to study intensively pathology this weekend, and then you can manage your preparation for your other final exams.
Monday, like,
Monday of finals week.
Oh, okay.
Exams are in finals week only. Okay. So I would still suggest that you do some significant exam preparation over the 3-day weekend. And the reason is we are doing a review next week. And you will get much more from your review if you have studied. It will be much more helpful. We have 1 hour extra time, so we actually have 2 hours of review time, our last session in class, and only 1 hour of new material. I intentionally chose our last topic to be something that most of the things in it you've been introduced to already in other courses, so a lot of it's review. So I'm really, really trying to limit the amount of new information in that last week for your benefit. What was I going to say? Oh, somebody said, well, if we studied this weekend, then we can't remember it for the final exam. So I want to remind you for this and all your courses, you're not studying for an exam, you're studying for a career. If you can't remember it a week or a week and a half or 2 weeks, you don't know it. And you're not going to carry it with you to practice. So make sure that you're investing in study methods for all your courses that are going to give you retention. So if you put in a lot of good quality study time this weekend, it's still going to be with you in finals week. Okay? And plan your preparation time for all of your courses so you have enough for all of them. This is not the only course you're taking. And the time that you spend in exam preparation needs to reflect that and respect that. You don't want to put all your eggs in one basket, okay? We are finishing our discussion of bony lesions, and we do need to get a move on or we're not going to get through them. We pick up our discussion with the benign fibrillosseous lesions. This is the one group of jaw lesions that is not an etiologic category. This is a category of disease based on histologic presentation. What these diseases have in common is that histologically, they have little bits of bony tissue smaller than normal trabeculae, separated by fibrous connective tissue. And we call them generically benign fibrillosseous lesions. Why do pathologists use this term? Because the histology isn't often distinctive. We depend on histology to give us definitive diagnosis. But for this group of lesions, the histology is so similar that we often cannot make a definitive diagnosis on the basis of histology. And the best diagnosis always requires a correlation of clinical, radiographic, and histologic findings. So the clinical information is absolutely essential. And if the pathologist doesn't get enough clinical information and receive radiographs when they get these biopsies, the diagnosis that goes back to the surgeon is benign fibrillosseous lesion, NOS, not otherwise specified. Can't be more specific. So these are diseases that are more challenging to diagnose histologically than they are clinically, which is kind of good for you because they're easier to diagnose clinically. They have different etiologies, so you do need to keep track of what etiologic category they belong to, since that's not implied by the group that they are in. By far and away, the most common benign fibrillosseous lesion that we see in the jaws is the family of cementoosseous dysplasias. At times, we have called them segmental dysplasias. At times we have called them osseous dysplasias. There's more than one pattern, and they used to be thought to be independent diseases, and we now recognize them as a spectrum of disease that's all related. So we've kind of agreed to call them cemento-osseous dysplasias. It'll probably change again before you retire. It's changed several times over my career, but currently the preferred terminology is cemento-osseous dysplasia. We are going to look at the two most common of the three types. The third one is rare enough that we don't need to talk about it. And you do have to specify the type in your diagnosis. If you just say generically cemento-osseous dysplasia, that's not enough and you don't receive credit. Regardless of which form of disease it is, they all go through 3 stages radiographically. These are 3 stages radiographically. Clinically, there really aren't any changes. This is usually an incidental finding on radiographs. There's no bony enlargement. Teeth are vital. There are no symptoms. The 3 stages they go through, the early stage removes normal bone and replaces it with the fibrous part of the cemento-osseous dysplasia, that benign fibroosseous lesion. So it's going to be a pure radiolucency. And as it matures, it moves into an intermediate, what we call blastic stage, where we have formation of hard tissue, bony tissue or cementum. Histologically, it's almost impossible to distinguish between bone and cementum. So that's why we kind of call it cemento-osseous, because we're not sure which. But when we're in this blastic stage and are starting to form hard tissue, the radiographic lesion is going to be mixed. It's going to have some areas of opacity, more toward the middle. It's kind of a mixed opacity. It's not uniform, solid whiteout. It's kind of irregular, but it always has a radiolucent rim around it. And as it matures, the rim gets smaller and smaller, and the mixed part kind of gets bigger and bigger. The mature final stage, which then lasts for years and years, is an opacity that retains at least a partial radiolucent rim. Maybe a thin radiolucent rim. It may not be a complete radiolucent rim, but there will be at least a partial radiolucent rim around the opacity. An important radiographic finding in all of the different types in the spectrum is that even in the intermediate and mature stages where we have radiopaque parts to the lesion, the radiopaque parts will not obscure our view of the roots of teeth in the area. We are always able to see the teeth, and we're always able to see the periodontal ligament space between the teeth and the lesions. And that will become more obvious why that's important as we look at the 2 different types that we're going to study. By far and away, the most common pattern of cemento-osseous dysplasia is the periapical pattern. So the proper diagnostic term for it is periapical cemento-osseous dysplasia, which is a mouthful. If you substitute the first word for something else, it doesn't work. If you substitute the last word for something else, it doesn't work. If you fudge a little bit in the middle, you might get away with it. So if you called it periapical cemental dysplasia, you would get away with that. If you called it periapical osseous dysplasia, you would get away with that. But the preferred terminology is periapical cemento-osseous dysplasia. The disease on the spectrum that we use this as the diagnosis for is when the radiographic lesions of cemento-osseous dysplasia are confined to the anterior mandible. We call it the periapical pattern because these are classically lesions at the apex of multiple mandibular incisors. In some patients, we also see it at the apices of 1 or more cuspids, so it could be 1 or both. And occasionally it'll move into the bicuspid region. But if we're moving further posterior than bicuspid teeth, then we should be considering a different pattern. So we really want to have lesions that are confined to the anterior mandible. Patients who have periapical cemento-osseous dysplasia are adults. This typically starts in the 30s and is diagnosed around age 40. It is very unusual to have any manifestations prior to age 30. So this is not a young person disease. And of course, once you have it forever. It doesn't go away. It just stays there. And so the patient could be quite a bit over 40, because they have it forever. But about in the 40s is a common age of diagnosis. This is a disease that has a very strong female gender predilection, up to 14 times more common in females. I have seen this on only very rare occasions in my career in men. It is a strongly female disease, and it also has a strong racial predilection. 70% of patients in published reports are African American or African heritage individuals, Black Africans. The remainder are almost always non-Caucasians. So the other 30% are usually Hispanic or Asian. It is uncommon in Caucasians. It's not impossible, but it is distinctly uncommon in Caucasians. So this strongly suggests that there is some type of genetic predisposition that is linked to both gender and race. There's something in that gene pool, but it's never been identified. We don't know exactly what causes this disease. We do know that it's associated with vital teeth, and it's typically completely asymptomatic and non-expansile. So I brought some examples. And what phase would this be? So what do you see? Pure radiolucencies at the apices of 4 incisors. When we look at the crowns of the teeth, it looks like they might have reasons for periapical lesions of inflammatory origin. One of them's had a root canal and had an all-ceramic crown that doesn't show up on the radiograph. But that root canal was done because they didn't trust their testing and they misdiagnosed it. It was actually a vital tooth. So we always have to do tooth vitality testing, and this is a condition associated with vital teeth. So in that early pure lucent stage, it can be easy to make an incorrect diagnosis of an inflammatory lesion, but if the pulp's not necrotic, it's not an inflammatory lesion, and root canal therapy doesn't do anything for this disease. How commonly would we expect to see multiple pure radiolucencies at the apices of a vital tooth of inflammatory origin? It's like that's not possible. So pulp vitality testing is very, very important. And when you put pulp vitality testing with radiographic features, that becomes diagnostic, and biopsy is not necessary to confirm the diagnosis. What do we see in this patient? Lucent opaque or mixed?
Mixed.
It's mixed. It's mostly lucent, but it's getting areas of opacity right in the middle, and my secondary pointer thing is not showing up. Why is it not showing up? It's flashing and then disappearing. Once it's mixed, you should never think that it's of inflammatory origin. Those things that arise with non-vital teeth are never mixed. They're always pure lucent. Here's another one. This was a patient here at the school that we followed over time. Top radiograph is at age 39. That's a 39-year-old black female, in case you were wondering what that meant. And that's in the mixed stage, where we have some opacity in the center and some radiolucency around it, and there are multiple lesions. And then when she was 45, see how the opacity is more uniform and distinct and larger, but there's still a radiolucent rim around it. It's matured very nicely. And both of those are very, very characteristic, very, very diagnostic for this condition. I want to back up real quick. Treatment for periapical cementoosseous dysplasia is to make a correct diagnosis and not provide incorrect treatment. Don't tell the patient that they need a root canal, or if they can't afford it, have the tooth extracted. So this requires no treatment. It should just be monitored. And saving teeth is very important. Preserving the dentition is very important. Some patients with periapical cementoosseous dysplasia can progress over time to florid cementoosseous dysplasia. Other times, it seems to be florid cementoosseous dysplasia from the beginning. What are the arbitrary rules that we use to call it the florid type? Does anybody know what florid means? My quick and dirty definition of florid is over the top. It means extensive. So we arbitrarily call cementoosseous dysplasia florid cementoosseous dysplasia when we have multiple lesions and they involve all 4 quadrants. Mandibular lesions typically involve the anterior and posterior mandible. In occasional patients, it's just posterior mandible. But most patients have anterior lesions. Also, we very frequently have fewer lesions in the maxillary arch, but there are usually at least a few and on either side of midline. What would we use as the diagnostic term if they have lesions, lots and lots in the mandible, anterior, posterior, and maybe 2 lesions in the maxilla, but they're all on one side, so we only have 3 quadrants? What would you call it? You would call it the florid form. So some patients don't fit the exact arbitrary definitions, so you put them in the nearest one that fits. That would still be extensive lesions, and so it still fits better with florid cementoosseous dysplasia than periapical cementoosseous dysplasia. These patients tend to be a little bit older than we see the periapical type, possibly because it is a more advanced form of the disease and it took them a longer time to get there. So it tends to be middle-aged and older adults. 90% are older adult African American females or African females. 90%. Very, very, very strong age, gender, race predilection for this type. Very, very, very strong. Again, teeth are going to be vital unless they have some obvious huge decay and pulpal problem. Then they could also have inflammatory periapical lesions, but typically they don't. It's asymptomatic most of the time. Occasionally we can get focal expansion, but most of the time, just like the other patterns, there's no bony expansion. And these lesions are prone to secondary infection. So if we do have infection that spreads down the PDL from periodontal disease, or infection from a pulp that got infected, if the infection gets into this abnormal tissue, it doesn't cope with it well because it doesn't have a good blood supply, and so we can get persistent secondary infection that can be quite symptomatic. Tends to be dull aching pain rather than that acute throbbing pain, but they can get pain because of secondary infection. It's not a real common problem though. So this was a mixed race, African American Hispanic female, 38 years old, seen here at the School of Dentistry. And she had multiple lesions in the posterior mandible and like 1 maxillary lesion that didn't show up very well on radiographs because a student took the radiographs. These things happen. So we decided it was enough to call it florid. We wouldn't call it periapical, so we still called it florid. But you'll notice that the lesions are still opaque in the center with a radiolucent rim, tend to be in the tooth-bearing area. Not so much strictly in the periapical area, but some of them are. And so fits beautifully with cementoosseous dysplasia, not as neat and cleanly into one of the arbitrary types, but it's still a very nice cementoosseous dysplasia. This is an older adult female with lots of lesions. It's a panel with lots of artifact, but there's 1 maxillary lesion. There's another maxillary lesion, and she's got some back here. They don't show up so well. But look at all of the lesions in the mandible. Lots of them. Large, confluent, at least partial radiolucent rims. Where are the teeth? They're gone. They're gone. And we tend to see patients where They weren't diagnosed properly early in the course of disease. They didn't have much money. When they were told they needed a root canal, they said, I can't afford it. The alternative was to extract teeth, give a denture. That is absolutely to be avoided at all costs. And the reason is that over time, after you extract teeth, the alveolar ridge resorbs. And then when it resorbs down to this abnormal tissue, it causes problems. We get denture sore spots and ulcers, and then we get infection in this abnormal bone, and then it dies and sequesters, and we have to do surgery. It's a huge mess. Huge, huge mess. So accurate diagnosis and preservation of the dentition is extremely important for these patients. One more thing. You cannot put implants in this tissue. Doing surgery into the tissue to place an implant causes complications and is specifically contraindicated by results of scientific studies, published studies. So extracting and placing an implant is not an option either. Preservation of the dentition is important. John, question?
So if you leave it alone, it will stay there and it wouldn't cause any
If you leave it alone, it'll stay there and not cause problems as long as you keep the teeth and periodontal health very, very good, so there's no opportunity for secondary infection. The only other problem that they sometimes get is they can get simple bone cysts. Simple bone cysts usually occur in young people, but these individuals, the abnormal tissue is prone to getting simple bone cysts. So they do need regular radiographic reevaluation, like a new pano every 3 to 5 years, just to make sure nothing untoward is going on. But that's not a common complication, but it is possible.
How about after extractions?
After extractions, though, they can have lots of problems. That's an opportunity for infection as well. We really want to avoid infection in this abnormal tissue. You can see it's very dense. It has very, very poor blood supply, very, very poor host resistance to infection. Last question.
Will that still be considered a bone scar?
No. Bone scar is residual condensing osteitis. Sometimes we use the term residual osteosclerosis for residual idiopathic osteosclerosis after a tooth is extracted, but this is always cemento osseous dysplasia. It doesn't matter. We don't change the diagnosis because you've lost teeth. Not called a bone scar. Yes?
Is the fluoride, I'm saying it wrong,
Florid.
is this one ever, because I know it's in 4 quadrants, can it start in the anterior?
Oh, it often starts in the anterior mandible, and then more and more lesions appear over time, and it moves further back, and then we have those on the maxilla as well.
So
That's
how
a
do
common
you
scenario.
differentiate between
We differentiate based on where they are at the time we make our initial diagnosis. We follow the patient, and the diagnosis may change. Over time, we may change. It may start out as periapical cemento-osseous dysplasia, and then over time, we change it to florid cemento-osseous dysplasia when they get more lesions. So that's another reason to monitor them radiographically every 5 years or so. Okay. These are good questions. This was a patient that we saw here at the school some years ago, actually the mother-in-law of one of our students, and she had undiagnosed florid cemento-osseous dysplasia and had teeth removed and had dentures placed and had resorption of the ridges down to the abnormal bone, and 2 areas became infected and sequestered through. And before she could have new dentures made, that had to be curetted out surgically, and she had to be on antibiotics to make sure everything healed and there was no residual infection and there was primary closure over the top, and it was a long, hard battle for her. So avoiding that is preferable to dealing with it. All right, I think we have already talked about treatment adequately and our prognostic factors. We talked about that with the different types, so we will take a break and come back and talk about fibrous dysplasia. 10-minute break, come back at 2 after the hour.
Thank you so much for the mentor, and One more question. So, is there any way, please, if we mention something, but I didn't mention it's compound, or because I didn't know I should mention that, but I mentioned it's odonto, but I didn't mention it's complex or compound. Is there any way that we have a little bit credit or no? Not? Oh,
Just a second. Thank you. I'm trying to, my pointer is not doing what it's supposed to do.
I don't oppose. I used to never use essential oil. I didn't ever got to that. Where the first 50. I don't care. Is that what I was How are you guys gonna get it? I think there will
See if this works. Okay. You didn't specify the type of odontoma. That is part of what you absolutely have to do. And you should know, if you paid attention in class or paid attention to your handouts, that would be expected. So it's highly unlikely you will get credit.
not at all. Zero?
That's not my question, and I'm not scoring it, but it's highly unlikely that you will get credit.
Okay, thank you so much.
Because we always expect that it's the type is specified.
Okay, thank you so much.
Not the last one, for the parody. I already forgot the name. But where it had the radiolucencies at the roots, is that does it cause like the teeth to be weaker? No. So then, what is the radiolucency like?
It's like a capsule of fibrous tissue. So this is a fibroosseous lesion, and in the beginning, in that lytic stage, it's mostly the fibrous tissue, and then it gets more ossified or bony or cement-type tissue over time, but it always retains a rim of that fibrous tissue. So that's just the fibrous part that persists at that edge.
Okay.
Yes, and it's adequate for mechanical support.
Okay.
It doesn't cause problems with mechanical support for the teeth or strength of the jaw.
And then too, I wanted to ask you, when somebody has an abscess and like they put the patient on antibiotics, right? And
Yes.
they do a root canal, does the bone rebuild itself after time?
After the infection resolves, oh yeah.
Okay.
The bone can heal very nicely.
Okay. Well, because my husband, he had a root canal and then it got reinfected. But we ended up extracting the tooth because he had a CVC and it was like the infection was just, and they weren't sure if another root canal was going to work.
Yeah.
But I was just like, remember?
If the bone doesn't heal, that usually means persistence of disease.
Okay.
So it's either persistent infection or a cyst developed, a radicular cyst developed.
Well, we just ended up getting it extracted, but I was thinking like.
So what if it's a radicular cyst? Is it going to go away from just extracting the
No,
tooth?
but the infection, like you could.
There was drainage and stuff. Then CVC can usually distinguish between active infection.
Yeah, I was just curious because I didn't know. I always was confused, like, because it was radiolucent. I'm like, does the bone just come back?
No, it does. It heals nicely.
That's
And
interesting.
sometimes we have complications of healing and we get a fibrous healing defect. So it fills in with fibrous tissue, like a scar, soft tissue scar instead of bone tissue. But that's very uncommon.
But even if they have a huge infection, if they start antibiotics, there's a possibility it could.
Yeah, you got to get rid of the source of the infection and do the antibiotics. And yeah, that can totally do
It's
it.
crazy.
Bodies are amazing.
Yeah. Thank you.
Are we going to start right now?
We are going to start in 5 minutes.
Okay,
We
so-
get a full 10-minute break.
Okay, I just had a question about the email I sent.
Yes.
So, do I go speak to Kristen Marsh and then go upstairs?
No, you talk to Christina upstairs first because there's paperwork that has to be filled out.
Oh, okay.
And she sent you an email as well. Yeah, so you start with Christina on the 5th floor, and you'll find out there what signatures you need.
Okay.
But it is important to get that done right away.
Okay.
Because The grading system only allows us to put in certain grades. So if a grade is designated as a letter grade course, A, B, C, D, E, F, G, whatever, it won't let you put I for incomplete. It won't let you put pass, fail. It won't let you enter any of those. So when grades are due, if that's not in with records and approved, then the only option I have is to give you the grade you earned, which would have to be an F if you haven't taken the exam. So we don't want to do that.
Yeah,
So we really don't want to do that. So it's important to get that process right away so it's in the system and I can enter that incomplete grade.
Okay.
And sometimes we have to decide what is our time frame for you to make up the course. The very latest they will let it go is the end of the following quarter, but we usually don't want to go that long because it gives you more time to forget things and we don't want to do that. So usually it's a month after your return, which would be the end of July or maybe the first week of August because we have so much holiday time in July. So, and that gives us plenty of time to look at your schedule and find a good time to do it where it doesn't compete with any of your exams for your new quarter. So we want to wait until you have your schedule for your new courses, and then we can sit down and plan a time to do your remediation exam.
So there's no way I can take the exam earlier?
The likelihood that it's available earlier is slim to none, which is one of the reasons we couldn't have the exam on Monday. Is we simply can't get it done.
Okay.
Dr. Grandi is out of town for a professional conference next week for part of the week, plus during finals week, and we are very, very challenged to get this final exam done. Furthermore, if we have students taking exams on different dates and can talk to each other, they have to be separate exams. They have to be different exams.
Okay.
So that's my policy.
Okay, I'll go speak to Kristen upstairs.
Christina.
Christine, I'm bad at names.
She's very helpful.
Okay, I'll go talk to her and then I just follow up with you on what she said? Or?
Yep, she works with those records kinds of things all the time. I do those incomplete grades once every few years at the most, and so I sometimes forget all of the details. So she knows the details and can tell you exactly how to do it right.
Okay, all right, thank you.
We send you to the person who knows the most about it.
Thank you.
All right, good luck with that.
Yeah, it's only two. This one is those.
The one more is the one we're going to learn next
Oh, that day.
Would you stop there?
I do at the end.
Yeah. Okay, ready? 1, 2, 3. We made it. No way to
make an announcement.
Yeah. 1, 2, 3. Happy birthday to you. Happy birthday to you. Happy birthday, dear Noe. Happy birthday to you.
So will your class choir be performing it next year? You guys sound way better than me. So you're not hearing any complaints from me. And so we pick up with our discussion of fibroosseous diseases, and we are going to move on to fibrous dysplasia, which is considered to be the classic fibroosseous disease. It is a developmental disorder, basically a hamartoma, that occurs from a mutation early in life. It's not an inherited mutation, but it occurs early in life. And so the alteration in bone that occurs is going to be during those growth and development years. And when skeletal growth and development is complete, this stops growing. Sometimes it stops growing a little slightly later, but generally it stops growing then too. So it stabilizes and it responds to normal growth regulatory controls. But the mutation, and we know what gene it is, but you guys don't need to know that, but the mutation causes abnormal maturation of bone. And so instead of having normal bone, we get bone that has these small irregular trabeculae of woven bone instead of mature lamellar bone, and it's separated by fibrous tissue instead of normal hematopoietic bone marrow. Another feature is that it looks like the bone arises directly out of the fibrous tissue instead of having a rim of osteoblasts on the surface. It looks like it comes right out of the connective tissue. What else do you need to know about that? It comes in two different patterns, monostotic and polyostotic, and that simply refers to the number of lesions the patient has. Monostotic is by far and away the more common pattern, and mono means one. And that one lesion could be in the skeletal bone somewhere in the body, but it could also be in the jaws. And the most common pattern of fibrous dysplasia in the jaw is that monostotic pattern where there's just one lesion in one quadrant of the jaws. Polyostotic means there are multiple lesions affecting multiple bones. And we get polyostotic disease when that acquired mutation occurs earlier, much earlier. The most severe polyostotic form, we actually believe the mutation occurs during embryogenesis. And so the mutated gene gets transferred and propagated throughout the skeleton. And that's why we get so many lesions. Age of onset of lesions also depends on if it's monostotic, polyostotic, and that age at which the mutation is acquired. The monostotic common pattern, usually we don't see lesions until adolescence. It's very common for it to first be detected in the early to mid-teens. And it still can get fairly big by the time skeletal growth is complete. What age do girls usually stop growing their skeleton? Their bones stop growing at about age 18, and men?
25.
Well, I heard 23, but it's still in the 20s. Men continue to grow longer than women, so their lesions can get bigger because they're still getting skeletal growth. Polyostotic disease usually has childhood onset and sometimes early childhood, depending on which of the polyostotic patterns we have. There's more than one. I'm not sure if you have to know all the details as dental hygienist between the two different types of polyostotic disease. Clinical symptoms, signs and symptoms, it's just gradual bony expansion, and it's very subtle. But we get asymmetry. The bone in one quadrant of the jaws is going to be bigger. And it tends to have a blending edge to it. So it's a gradual fusiform tapering enlargement rather than like a sharply defined round mass. It doesn't look like a neoplasm. It's just this gradual, gentle enlargement that produces asymmetry. Radiographic presentation is also different depending on if it's the traditional common monostotic pattern or the lesser common polyostotic disease. The classic appearance is for monostotic lesions, and it's ground glass bone. Have we seen anything else that produces ground glass bone? Yes, hyperparathyroidism. Is that an expansile disease arising in teenagers? No. So the clinical presentation distinguishes them. Also, the fact that hyperparathyroidism is all four quadrants, and monostotic classic ground glass, one quadrant only. So there are lots of ways we can distinguish those two diseases, even though they both have ground glass bony changes. Polyostotic disease doesn't follow the rules, and on occasion lesions might look ground glass, but more often than not, they look like multilocular lucencies or even cotton wool pattern of bone, which you might not have learned yet, but we will learn that shortly. So it's extremely variable, and don't expect it to be our classic ground glass bone. So how old do you think she is? Doesn't she look like a teenager? I think she looks like a teenager. She doesn't quite look like she's in her 20s. I don't know why she's missing tooth number 9. That's independent. But when we look clinically in her mouth, you can see how this part of her maxilla is distinctly wider than the normal maxilla. She has a tooth missing here, and I'm not sure what that's about either. I don't think that had anything to do with the disease process. And what's this indentation from? She has a flipper to replace the missing teeth. Okay? Radiographically, do you see the ground glass bone? And can you tell it's expansile? Do you see a border to it? No, you don't see a border. If we have radiographs further anterior, we're going to see that there's a very gradual blending border with normal. You can't exactly put your finger where it changes from normal to abnormal. And that's typical. That blending border is typical. A sharply defined edge fits with a neoplasm. That blending border fits with a developmental process. Why do we have a distinct border at the superior aspect? Because we have an anatomic border, the floor of the sinuses, and that's different. But we even have some vertical expansion, so this is encroaching on the sinus space. This is a young man in his teens, and notice he has some facial asymmetry, but it's not hugely disfiguring, it's just the two sides don't match. So if we take an occlusal film, we can see the bony expansion very nicely. I think you've learned to do occlusal radiographs, and at this angle in view, we shouldn't see any buccal bone at all. It should all be tucked under the teeth, and here we see beautiful expansile area of ground glass bone with that uniform kind of stippled appearance. And then it just gradually transitions to normal toward midline. Doesn't cross midline for this patient. This is a patient who has polyostotic disease. Polyostotic disease is often much more on one side than the other, tends to be strongly unilateral, not exclusively unilateral, but strongly unilateral. It's displacing the orbit, it's causing mandibular disfigurement. This is another patient who's got cranial bone involvement and with expansion, and here's multilocular lucencies involving the entire humerus as well as multiple, both bones, ulna and radius in the arm. So, and other bones are going to be affected as well. This is a patient with polyostotic disease that's affecting both sides of the maxilla and the mandible. The mandible doesn't look as enlarged, but you can see with his radiograph kind of a cotton wool pattern, that clumpy increased opacity. Definitely not a ground glass pattern change. So he has some interesting changes. A lot of decay. I'm not sure why. Maybe he is discouraged and gave up on his teeth. I have this picture because it shows cafe au lait spots. Cafe au lait spots are classically seen in polyostotic disease and can be large and geographic. I kind of think that looks like Africa, maybe, and kind of has ragged edges to it, but cafe au lait spots are seen in this disease. Have we seen any other disease that has cafe au lait spots? No. Yes. Neurofibromatosis. Yes, and soft tissue lesions. But would you ever get those two diseases confused clinically? No, never. Never, never. We move on to another benign fibroosseous disease. Some people consider osteitis deformans to also be a metabolic disease. It is one that kind of defies etiologic classification because we don't know for sure exactly what causes it. Studies have shown viral particles in the nuclei of osteoblasts, osteocytes in affected bone. And so the prevalent etiologic theory is this is due to the latent effects of an early childhood ordinary virus. Viruses that have been implicated include measles, and respiratory syncytial virus, which are actually in the same family, but these are very early childhood infections. And we distinctly see this in individuals who are Caucasian of Northern European descent, especially English descent. So we actually think that there's a genetic predisposition. Depending on your genetic makeup, you respond differently to these viruses than somebody else does. But whatever the cause, when you get osteitis deformans, it produces abnormal bone remodeling when you get to adulthood. So there's a big gap between the age of your initiating infection, ordinary viral infection, and the time it affects your skeleton. We don't see this prior to age 40. That's publishable. It's a middle-aged and older adult. But we get this abnormal frenzied bone remodeling where eventually osteoblastic activity exceeds osteoclastic activity, and that causes deformity of bones over time and increased bone mass. But the increase in bone mass doesn't really benefit the patient. It's weaker than normal bone, and it is prone to fractures, so these patients do get pathologic fractures. The World Health Organization likes the name osteitis deformans. It's not an inflammatory disease, so we don't like that. Most physicians and pathologists call it Paget disease of bone, and you should know both names because they are both commonly used. National boards tends to use osteitis deformans because they like World Health Organization terms, but out in practice you're going to hear Paget disease of bone. So this is a bone biopsy, and you will see the lines in the middle of the bony trabeculae. See those lines? Those are reversal lines where we've had remodeling. This was all chewed up, removed by osteoclasts, and new bone placed. So one of the diagnostic features is excessive reversal lines showing excessive remodeling. And here we have a line of osteoblasts making new bone. And here on the other side of the trabeculae, we have osteoclasts chewing it up. So we can see osteoclastic activity and osteoblastic activity right next to each other, which is a very unusual finding and strongly indicative of Paget disease of bone. The picture to the right shows the different phases. The osteolytic phase that this goes through early in disease, where we tend to remove bone because there's more osteoclastic activity. We move quickly into the mixed middle prolonged phase, where we have that frenzied remodeling, where we have lots of both osteoclastic and osteoblastic activity, and then it tends to mature and burn out, where we get mostly osteoblastic activity and masses of dense sclerotic bone that's no longer being remodeled and becomes brittle and prone to fracture, if any of that makes sense. So we've already talked about the age of onset being adult, 40s and over. It does produce changes in multiple bones. It may start with one, but it is a polyostotic disease by nature, may or may not affect the jaws, commonly affects cranial bones even when it does not affect the jaws. So head and neck manifestations are very, very common in this disease. It can be asymptomatic for long periods of time, but then patients usually do get symptoms. They can have bone pain. They can have pain from nerve compression, altered cranial nerve function. If you have lesions in the cranial bones near the foramen and the bone gets bigger, what happens to the size of the foramen?
Shrinks.
It shrinks, and that compresses the nerve. And so you compress a cranial nerve, and then whatever it controls doesn't work right. So these are patients that can have very interesting and varied symptoms depending on the location of involvement of the cranial bones. So on the left, we have lateral skull film on, I shouldn't say film, image, because most people don't use real film anymore. Normal skull of a 22-year-old female. You can see the normal skull density. You can see the normal thickness of the cortex of the skull. On the right, we have a patient with Paget disease who is a 49-year-old female. You can see there is distinct thickening of the cortex. It's not densely opaque. It's kind of mixed. And we see clumpy opacity in the wall, in that lateral portion. and areas of expansion, and increased density in the base of the skull, which is where those foramina are as well. So that pattern, that clumpy opacity that we see, that's what we refer to as cotton wool. So if you want cotton balls, you buy them as cotton balls. But back in time, like in the 30s and 40s and 20s, they didn't make cotton balls. You bought cotton in rolls, sheets and rolls, and you just pulled off a tuft of cotton and made your own cotton ball, and you could pull off a little tuft or a big tuft, and they called those rolls of cotton wool. And this kind of looked like somebody took little tufts of cotton, white cotton, and plastered it all over the bones, and so that's where the name cotton wool pattern came from. It's kind of irrelevant now that we have real cotton balls. This was a lady from our local community that was seen at the School of Dentistry before my time. This was from the 70s. She came in at the stage of the middle picture and brought us a previous picture. The previous picture was from 1969 with the beautiful cat eye glasses. Don't you love that? The middle picture was from 1973. So it was only 4 years difference. What's the biggest difference besides she got new glasses or took them off?
The maxillary.
The maxillary height. You notice more maxillary height? That's a lot. We shouldn't have increased maxillary height, a growing maxillary height in an adult, an older adult clearly. What else do you know? Do you notice her nose, how it's tipping up? And that's because of the expansion in the maxilla. Yeah. And this is what she looks like from lateral view. You can see that the bony expansion is just obliterating the vestibule, and she has a very tall, bulky maxilla. And she also has some increased bulk in the posterior maxilla on one side. It's affecting her bite. And also has radiographic changes. You can see the increased bone height, but you see that clumpy increased opacity that fits with a cotton wool pattern. So this is a nice example of Paget disease of bone. We would expect that she has skeletal bones that are also affected. Who treats these patients? Physicians. So based on dental findings, if we have a suspicion of Paget disease of bone and a patient does not have a diagnosis yet, they do need to be referred to their primary care physician with our documentation for our suspicion, and then they do diagnostic testing. Do you think they want to do a bone biopsy? Would you want a bone biopsy? You have to take out an intact piece of bone, not little scraping. So bone biopsies are challenging, and luckily this disease can be diagnosed by a simple blood test that checks for serum alkaline phosphatase levels. That frenzied remodeling causes increased levels of serum alkaline phosphatase and will elevate them higher than any other disease process. So a really markedly elevated, severely elevated level of serum alkaline phosphatase is diagnostic for Paget disease of bone. So that kind of makes the diagnosis easier. These days they do some bone scans to see the extent of involvement, and then they plan their treatment. How are they going to treat this disease? They have to do something that's going to stop the remodeling or slow down the remodeling. And what works best are those high-dose IV bisphosphonate drugs that are known for complications. So sometimes the cure has some problems. It doesn't cure it. You have to be on treatment long-term, but it does stabilize the disease. It will not reverse it. So then we have to monitor for possible complications of spontaneous osteonecrosis. Patients with Paget disease can get some complications in the jaws. One of the known and better recognized complications is hypercementosis. So the remodeling process sometimes violates the PDL and starts removing tooth structure as well, so we can get resorption of the teeth and replacement with pagetoid bone, or we can get hypercementosis. So both of those are well-recognized complications, and patients need to be monitored for complications. We just hope that they never need to have those teeth extracted, because that's going to be really challenging. They are really anchored in there. Have you learned about hypercementosis in other courses where there's thickening of the cementum layer. It should always have a PDL on the outside. In Paget disease of bone, the PDL disappears. That's kind of part of the process. And so anytime we see hypercementosis, we look for a PDL. If we don't see it at all, we should be suspicious of Paget disease of bone. If we do see a nice PDL, then it's the ordinary type of hypercementosis that has nothing to do with Paget disease of bone. All right, our last fibroosseous lesion is also our first neoplasm, because right after this we move into the neoplasm. So this is a disease that's dual classified. It is both a neoplasm and a benign fibroosseous lesion. We currently call it ossifying fibroma. It has been called cementifying fibroma, central ossifying fibroma, cemento-ossifying fibroma. I think people get advances in their rank or something for publications for coming up with a new name to confuse us. And it's not right that things have so many names. So we only ask that you learn the preferred term for this one. But if by accident you use one of the other terms that is recognized, we know those terms and you will get credit. But please use the term ossifying fibroma. It is a true neoplasm. It is benign neoplasm. It grows slowly. It has a capsule around it. It doesn't stop growing unless you intervene, and it does require surgical excision. They still debate the cell of origin, which is why there are so many different names. But we think it has both a fibrous and osseous component. So ossifying fibroma is a good name for it. When we look at it histologically, it has small irregular trabeculae of woven bone with osteoblasts rimming the surface and fibrous stroma. Looks an awful lot like all of the other fibroosseous diseases, particularly fibrous dysplasia, but it is different radiographically and is different in its behavior. So you should be able to distinguish this from fibrous dysplasia. So who gets ossifying fibroma? Typically adults. It is seen most often in young adults. Occasionally we will see it in the late teens. And that's when we have to think really carefully, is this fibrous dysplasia or ossifying fibroma? But there are clues. And usually is diagnosed by age 40. We don't usually see new tumors in the over 40 age group. It prefers the mandible over the maxilla and tends to be in the body of the mandible area. Do you know what the body of the mandible is? It's not anterior mandible, not posterior mandible, that zone in between, that bicuspid first molar area is the body of the mandible. So it prefers the body of the mandible area. It is twice as common in females, but that still means 1 of 3 is a man, and so I don't think that gender predilection helps us very much diagnostically. Radiographically, because this is a neoplasm that slowly enlarges and has a capsule, it presents as a well-defined round to oval lesion that is lucent to mixed depending on how mature it is. So they tend to start out lucent and then they become mixed over time. And when they are in the pure lucent stage, there is nothing about them that says, hey, I'm an ossifying fibroma, so we don't even put it on our differential diagnosis for purely lucent lesions. We only consider it in the differential diagnosis for a lesion that's mixed. That's the only time you would have a suspicion that you're working with ossifying fibroma. So, is this lucent, opaque, or mixed? It's a pure lucency. It's well-defined. Teeth are vital. Has a little bit of a sclerotic rim. There's some increased density around it, but it's not the thin, white, corticated line. But there's nothing about that should make you be suspicious. It's ossifying fibroma. So I don't want to see that on your differential, even though when it was removed and examined histologically, that's what it ended up being. If you tell me that on a quiz, I know you're memorizing my slides and not using your brain. You don't want to do that because you're never going to see that patient in your practice. Don't memorize my slides. Use your brain. So you would think of something else. Probably something odontogenic in origin that's a pure lucency in the mandible. So we move on. Can you find the lesion? All right. So this is a panoramic radiograph from days gone by when we had lots of artifact in panoramic, particularly in the midline, and all of this is artifact as part of the process. So that's not the lesion. This is the lesion. And it's oval and it's well defined. And that little thing there is also artifact, and this area of generalized lucency matches this generalized lucency in his artifact. So the lesion is this. Do you see it? Okay. Now do you see it better? How would you describe it? Lucent, opaque, or mixed? Mixed. Mixed. Is it corticated or non-corticated?
Not corticated.
Aha. I need my pointer. Come on, pointer, show up. Don't flash. No, it's just ornery. It's been misbehaving since I got my new laptop. It's not talking to my laptop. I'm going to use my finger. Do you see this radiolucent line?
Yes.
That is the capsule. That is the radiolucent rim, and the white line around is the cortex. And I bet you thought it was all the lesion. Yeah, but that nice uniform, thin radiolucent rim separates the mixed lesion from the corticated border. Corticated border tells us it's growing slowly. That fits with a benign. This fits beautifully with a benign lesion. So it's well defined, corticated, nice and oval, uniform. Got to be a benign neoplasm. So we put ossifying fibroma in our repertoire of things that we would put on the differential diagnosis for this. And in an adult, 20 to 40, I would put ossifying fibroma top of my list. That's a good one. Did you see any odontogenic lesions that would have this uniform and a mixed lesion? The things that could be mixed tend to be clumpy and not uniform, more opacity in just one part and distinct lucency somewhere else. So you should not suspect an odontogenic lesion for this. What about complex odontoma? Does this look like a complex odontoma?
It doesn't have.
It's not quite dense enough. Those are really dense. Bone is not as dense as tooth structure. So these are less dense, and they first arise in young adults, whereas odontomas arise at an early age. So you shouldn't get it mixed up with a complex odontoma either. This is a beautiful, huge ossifying fibroma. I don't know why anybody lets their lesions get this big. This is an occlusal radiograph, but I like to show it for two reasons. One, see how the opacities throughout do not look like trabeculae. Therefore, they have to be produced by the lesion, and that makes it mixed, and they're throughout. So that means it's probably not odontogenic. We're working with a lesion of bone origin. See how you think about it? Okay. The other thing I want you to see is how round this is, like a golf ball. Round, 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 round. Equal distance this way as that way. That is also strongly indicative of a lesion of bony origin. What did you learn about most of the odontogenic lesions? They are bigger this way than they are this way. They never have as much buccolingual dimension as they do mesial and distal. That is a distinctly odontogenic characteristic. So when we see something that's perfectly round three-dimensionally, like a golf ball, that fits with a neoplasm of bony origin, not odontogenic origin. So that's why I like this case, because that demonstrates it so beautifully. Very, very nice. Because this does have a capsule, it is usually fairly easy to completely excise it and know you got the whole thing out, because it separates at that level of the capsule and they can get all of it out. So it does not usually recur However, it is not a simple excision just because of the size of the lesion, the fact that it's hard tissue, it's got calcified material in it. So a big lesion like this, you're going to be doing segmental resection and reconstruction. So it might be a significant major surgery, but at least they can get it all out, and it has a very low recurrence rate, and they can reconstruct the patient very nicely. Yes, question?
Can we always see the capsule in the radiographs or only?
It depends on the view that you get, but usually you can see the radiolucent rim that separates the lesion from the corticated border. Usually. Sometimes it's only in part of it that you can see it, which is very frustrating. But if you see it in anywhere, that's a big clue. All right. I want to spend a few minutes with osteoblastoma and osteoid osteoma. I don't want to spend a lot of time because these are not particularly common, but they are about the only other bone-forming benign neoplasms that we see in the jaws. They are pretty much indistinguishable on the basis of histology and also look extremely much like osteoblastoma, but don't have the clinical presentation attached to the root of a tooth. They are distinguished from each other on the basis of size, very arbitrarily. If the lesion gets bigger than 2 centimeters, we call it an osteoblastoma. If it stays small, particularly a centimeter or under, it's an osteoid osteoma. There are some biologic differences, but it's sometimes difficult to prove those. The osteoid osteomas have tissue on the inside that can make prostaglandin E2, which generates pain. Big pain, out of proportion to the size of the little tiny lesion, but the pain can be relieved by aspirin and ibuprofen because those block prostaglandin production. So they actually use the aspirin test as a clinical diagnostic test to kind of screen for osteoid osteoma, for bone lesions that are radiographically and clinically suspicious. Our osteoblastomas can have pain, but it may or may not be relieved by aspirin. They often don't make prostaglandin. So there seem to be some differences between these two tumors, but they're so hard to distinguish that we just kind of consider them to be on the same spectrum, and we separate them by the basis of size alone. They tend to be a young person disease, under age 30, and most often actually under age 20. Have you learned a lot of things that are in kids under 10? That's a special group to pay attention to because we don't see a lot of things in under 10. Then we see a lot more things from 10 to 20, and 20 to 30, starting to pick up some of the adult things and lose some of those early age kinds of things. But age can be very helpful in picking the best diagnosis. These are neoplasms, so they present as well-defined, usually 3-dimensionally round to oval lesions. They don't have a strong site predilection. This young girl is 10 years old. You can see she's got an expansile maxillary lesion. It's distorting the nose. It is encroaching into the palatal space as well as going outward, so it is 3-dimensional, not just anterior to posterior. And here we have a nice round lesion that on a pano is hard to decide if it's lucent, opaque, or mixed. It's a little bit ground glass in this part, but it's increased density compared to normal bone, I think. What about this one? A little easier to see. This was a 16-year-old. She was only aware of the lesion for 5 months, but by the time it was detected, it was radiographically 4 centimeters. Bony heart expansion, posterior maxilla. Lucent, opaque, or mixed? Mixed. Border reaction. What do you see? It's corticated, but I don't see a distinct radiolucent rim on this one. And the teeth are superimposed on it. But I like this case because when you look at the density of the lesion, of that mixed lesion, what does it most closely match for our normal structures? Is it the same density as the enamel or the dentin of the teeth? No. It's almost identical density to the normal bone in the mandible. So that's strongly suggestive of a lesion of bony origin. So you should give me a benign neoplasm of bony origin because it's beautifully round and corticated. So it's got to be a benign bone forming tumor. We don't know much. Is this bigger than 2 centimeter? Then it could be osteoblastoma. What else could it be? Ossifying fibroma. Could be either one. I'd be really happy if you thought of either one of those. So that's how we think about it. More neoplasms. We don't have a lot of other neoplasms to look at. One of the things we have to think about for bony neoplasms is the concept of primary versus not. Because bones are a complex organ, and we have a variety of tissues in the bone marrow, and we can have tumors arise from the hematopoietic cells in the bone marrow. Those are not primary bone tumors. Even though they arise in bones, they're not of bone-forming tissues. They are primary to the hematopoietic system. And sometimes we get neoplasms that arise from the connective tissues, from fibroblasts. So you could get a fibrosarcoma, heaven forbid. You could get something of neural origin in a bone. But those are not primary bone tumors either. Even though they're primary inside of a bone, they are primary to neural tissue or fibrous connective tissue. So we use the term primary bone tissue for bony lesions that are of origin of bone-forming tissue. Does that make sense? And then as soon as we make that rule, we break it. Why do we do that? I don't know. Anyway. So the first lesion that we traditionally put in this category of neoplasms is the one that breaks the rules, and we argue, is it a neoplasm or is it a reactive lesion? There is an identical lesion histologically in the skeleton that is considered a neoplasm that is called central giant cell tumor. Tradition says the jaw lesions are reactive, and we call them central giant cell granuloma, but it could be a tumor. Where I trained, we considered them tumors. We always called them central giant cell tumor. I don't care which one you call it. You can call it either one, and there's going to be somebody who agrees with you. So, what is the cell of origin? We're not sure, but it exclusively occurs in bones, and it doesn't seem to be of hematopoietic origin or the other things, so we still call it a primary bone tumor. So we make these rules and then we break them. This is a bone lesion that occurs over a wide age range, but most patients are on the young side. Wide age range, but most patients are on the young side and can be under 10 years of age. Strongly prefers the mandible, but can be anterior, posterior, and can cross midline. And usually the only symptom is jaw enlargement. Occasionally there is pain, but usually it's no symptoms, just jaw enlargement. And it is a pure lucency. In the skeleton, classic lesions are a soap bubble multilocular lucency, but we don't often see that pattern in the jaws. These are the only two I have in my files of a soap bubble multilocular lucency for a central giant cell granuloma in the jaws. Most of the time they're unilocular, but they are always pure lucencies, and the most distinctive feature I've come up with that helps me have a suspicion for central giant cell granuloma or central giant cell tumor, if you wish to call it that, is the fact that there's no bone reaction. It has a punched out border. It goes directly from pure lucency to normal bone on the outside without a cortex. What is this? The residual trabeculation of the bone in front or behind it. But if you did a CBCT on that, the lesion would be all lucid. No bone in it. No bone in it. So it has that nice punched out border, and it's expansile. Here's one in the anterior mandible that's crossing midline, and it looks like it's maybe slightly multilocular, but even at the edges, there's no bone reaction. There's no cortication. So absence of cortication for a pure lucency that's expansile one of the things you want to consider is central giant cell granuloma. Definitive diagnosis is made histologically, and we will see very vascular, cellular, fibrous tissue that looks like granulation tissue. It's a little more mature than that, but it is very vascular and very cellular, with lots of multinucleated giant cells. These multinucleated giant cells are not osteoclasts. They are part of the lesion, but they don't have markers for osteoclasts. But this looks very much like something else that we've seen histologically, and that's that brown tumor of hyperparathyroidism. So if this is seen in an adult over 40, we would always test for hyperparathyroidism. In a young person, doesn't fit with hyperparathyroidism unless we have a history, medical history that says otherwise, and that would fit with central giant cell granuloma. Question?
Are we going to be focusing more on the unilocular or the multilocular, or just know that it's both?
It can be both, but unilocular is more common, so that's the one I hope you would have the greater suspicion for the lesions.
Because that macho thing that we learned
Yes.
was in there, so my
Yes,
mind
it is in there. The macho thing is in there.
but it's still.
But one of the ways you can distinguish this from other multilocular lucencies is the edge of it. And the age of the patient. This does tend to be a little younger than like conventional ameloblastoma. Conventional ameloblastoma, multilocular, it has some cortication at the edge of the loculations, at the outside border, whereas this is punched out. And so radiographically, you can usually tell it's not one of the others. How would you distinguish it from odontogenic myxoma? Odontogenic myxoma has really small loculations and very delicate residual bone forming the trabeculate. Very, very delicate. Can look quite similar to this. Which is more common? Odontogenic myxoma. I would always put odontogenic myxoma higher on my differential. And the others, they're usually other clues, location or age or something like that. So you can prioritize them, but you might have them all on your differential. That's why we have the macho list. I learned the coach list. It's basically the same thing. I should show you the coach list. Anyway, this does not have a capsule, so you can't peel it out by the capsule. It does have to be scraped out in bits and pieces with a sharp curette. And because of that, sometimes it's hard to tell when the surgeon can't tell if they have it all out. And it does have a higher recurrence rate than other types of benign conditions just because of the difficulty removing it. So patients have to be monitored for recurrence. We move on to malignancies. There are only two primary malignancies of bone that are worth mentioning. The single most common cancer in bone is not of bony origin. It's not primary bone. Single most common is metastatic cancers that have gone to the bones, including the jaws. Even in the jaws, metastatic cancer is far more common than any primary. Second most common one is multiple myeloma, which is a cancer of plasma cells, so it's a cancer of hematopoietic origin. Leukemias arise in the bones, but often we don't see them in the jaw marrow, but it's possible to have them. So we kind of work through those kinds of things before we get to any of the primary bone cancers. And primary bone cancers in the jaws are way less common than metastatic lesions or multiple myeloma. So it's really, even though osteosarcoma is the most common primary bone cancer in the jaws, it is not a common disease at all. It is not. You still have to know about it, but it is not a common tumor. Far more likely to have those other things. The good thing is we can usually tell when we're working with one or the other because of the ages. Metastatic cancers to the jaws are going to be in older people who get the primary cancers like breast and prostate, whereas our primary tumors tend to be in a younger population, and that helps. That helps. Same with multiple myeloma. It's an older adult disease. So there are some predisposing factors that increase the risk of getting osteosarcoma. Paget disease of bone is one of them. Prior high dose radiation, bony radiation to the jaws for cancer usually is another one of those. Those would cause adult onset osteosarcoma rather than the ordinary idiopathic younger age of onset. So, and a little bit more in osteogenesis imperfecta. I don't care if you know about that one. Osteosarcoma of the jaws tends to arise in young adults aged 20 to 40, so it is younger than those metastatic age group types of lesions. And it does not have a strong site predilection, so that doesn't help you. Single most common presenting sign is pain for no reason, and then bony enlargement. The pain often precedes the bony enlargement. They can get loose teeth, drifting teeth, things like that. Bony enlargement and drifting teeth and loose teeth are more advanced lesions. It would be nice if we could catch them earlier and we could cure them. When patients get osteosarcoma in the skeletal bones, it's usually young males, like 10 to 15 to 20, and it's usually in the bones on either side of the knee, and it's usually a big mass with a sunburst pattern. That's a totally different scale than what we see in the jaws. And if we wait for jaw lesions to have a sunburst pattern, like this one, that patient's going to die. There is really no hope of curing a patient that has an osteosarcoma that is so big to have a sunburst pattern like this. This is a very advanced disease. Patient probably already has metastasis to the lungs by the time it gets like this. So osteosarcoma of the jaws, we don't look for the sunburst pattern. We want to look for the early findings that suggest we might be working with an osteosarcoma. So unexplained pain, increased bone density, smaller expansile lesions, and it's a hard diagnosis to make, and one that I would probably not expect a hygienist to make. Most general dentists miss them too.
In that picture on the posterior molar, did the osteosarcoma erode the roots? Or is that just...
I don't know the story on this one,
Okay.
so I can't answer it. This might have been a younger patient, younger than typical, and that's just an completely formed third molar because the first molar is missing. That's a third molar.
Okay.
So this is one that didn't read the book and got it before age 20. The case that I've worked with, that actually the patient was in our hygiene clinic too. She had symptoms before age 20, and nobody could figure it out. And it became obvious around 21. And did not have a good outcome at all. So how old does she look? She looks pretty young, but she looks like an adult, maybe late teens. And she just has a little bit of bony expansion. Looks fairly gradual. Not that remarkable. It's displacing teeth. When you look at the radiograph, the first thing you should probably say is, where's the lesion? Because it produces calcified material, it is an osteosarcoma. It produces osteoid that mineralizes. It produces density of lesion that's similar to bone, but doesn't have a normal trabecular pattern, and that can make it difficult to identify. But all of this is the osteosarcoma. And I bet you didn't even think about that as, oh, that's abnormal. So these can be very deceptive, which is totally ornery and not nice. Histologically, we have bits of abnormal bone, usually lots and lots of osteoblasts, more lacunae than normal, very abnormal osteoblasts filling the space between the trabeculae. I would never expect you to recognize these histologically, but they do show signs of malignancy histologically and signs of bone morphologic differentiation. So we know that they're osteosarcomas. So what are some of the early findings that we might see that would help us know we're working with osteosarcoma? Mobility of teeth, pain for no apparent reason, widened PDLs. Widened PDL that goes all the way around a tooth that's vital instead of just at the apex of a tooth that's non-vital. We are always very suspicious when we have a widened PDL that goes all the way around the tooth that has no inflammatory origin. That is a sign of tumor and usually malignancy, and one of the things that can do it is osteosarcoma. If you look carefully though on the patient on the left, that is not a normal trabecular pattern in between. But it's subtly deceptive, and our brains don't read it as being abnormal bone. What about the one on the right? Do you see abnormal bone? Does this look like normal trabeculae? No. But it just doesn't look that bad. And so these can be deceptively innocuous, and it's a deadly, deadly disease. So having a suspicion and getting a patient in for proper diagnosis and getting a biopsy is really important, even though they say, oh, I don't want a bone biopsy. It's like, yeah, they got to have it. This one, do you think you see abnormal changes? Do you see the widened PDL? Yeah, that goes around. Notice, come on, let's go back. Notice how the density of the alveolar bone progressively gets more dense as we go anterior to posterior. So up here it's fairly normal, and then here it's getting more dense and a little clumpy and more dense, and then we get a little spiking on the alveolar crest. That is not normal. We should have a distinct edge to the cortex, and here we get some opaque spiking, and here very distinct opaque spiking. That's when I think it's fair game that you would have a suspicion that that's a bone-forming malignancy. It's ill-defined, has a vague edge to it. This patient is complaining of drifting teeth, tooth mobility, pain. You put it all together, hopefully you would have a suspicion of osteosarcoma. Is it an easy diagnosis? No, it's a really hard one. I think it's a really hard one. So these sometimes get missed. Osteosarcoma is treated by radical surgical resection. Osteosarcoma in the skeleton, those lesions that are most commonly either just below or just above the knee, they amputate with a wide margin, like a foot. They can amputate all the way up at the hip sometimes. Just leave a little stump of bone. Can we take a 12-inch margin of normal tissue in the jaws? No. Not without a guillotine. Patients won't consent to that. Chop your head off? I don't think so. So we get as big a margin as we can, but it's not ideal. It's not ideal. And because of that, osteosarcomas are hard to cure unless we catch them early, and they are still very small. Chemotherapy is often used as adjunctive therapy. It does help control metastasis. If there's already widely recognized metastasis, it won't eliminate it. But if we use chemotherapy in addition to surgery, if there's a cell that's out there moving around looking for a new home, it can kill it before it has a chance to take up housekeeping. But metastasis to the lungs is very common, associated with a poor prognosis. If we can get early diagnosis and adequate resection, we can get survival up to about 80%, 5-year survival rate, but long-term survival is not the best, and survival rates vary from study to study. When you put everybody together, it can be as low as 30% 5-year survival, up to 70% general population. It's just not real good. It's not a good tumor to have. It is what we in pathology call a bad actor. So we would like to catch them early and save our patients. I'm going to keep you over for just a few minutes because it was a quiz day, so we keep you a little longer. Chondrosarcoma is the second most common primary bone cancer in the jaws. It is a distant second. You should know it by name as a primary bone cancer, but we are not going to talk about it. It is very, very rare. I will not show you one in a clinical case. Okay? I just want you to know that it exists. I already said that the most common cancer in the jaws is metastatic from somewhere else, usually carcinomas coming from some other site in a middle-aged and typically older adult. These are patients who present with jaw enlargement, maybe pain, maybe loose teeth, maybe pathologic fracture. Most of the time our metastatic cancers are destructive of normal bone and replace normal bone. So typically we get ill-defined, moth-eaten radiolucency or an expanding radiolucent mass. There are a couple of exceptions. Most common cancers that metastasize to jaws, number 1 is breast, typically a female patient. Number 2 is lung cancer, which could be male or female. Those are nearby, not surprising. Kidney, 15%, that's a little surprising. And then 5% each, thyroid, prostate, colon, stomach. But carcinomas, they tend to be carcinomas. But breast, lung, kidney are common. Do you see an ill-defined radiolucency affecting several teeth? History of tooth mobility? Hopefully you'd at least be suspicious of malignancy, and if it's an older adult, metastatic carcinoma should be top of your list. Do you notice how it's causing some internal resorption? It's actually invading the pulps of the teeth and resorbing from the inside. Cancers can do that. Kind of cool. That one came from the eyelid. Adnexal structures the eyelash, forming something or other. I don't expect you to know where it came from, but that's what they found out. Do you see the lesion in this patient? This was a patient complaining of vague pain, older adult. Upper left, upper right, lower left, lower right. Which quadrant?
Lower right.
Lower right. This is the lesion. A vague, ill-defined radiolucency. They can be hard to see. If it's a female, top of my list would be metastatic breast. If it's a male, top of my list would be lung. That one ended up being prostate. This one has a short story. This was a patient who developed jaw pain and went to the dentist for jaw pain. And the dentist said, "Oh, you must have an infected tooth." Put him on antibiotics. And it felt better for weeks, a few months. Went back a few months later with more pain. And so, do you see a lesion here with the initial presentation? Does it look like the pulp and periapical things that we studied? No. Do we see a well-defined periapical lucency? No. So I'm not sure what the dentist was thinking, and there's kind of some vague bony changes. So that one ended up being metastatic breast, but I want you to notice something in this one. When the patient went back with more pain, and it was still there, and they finally biopsied it and figured out what it was. Even from the beginning, there was an area of increased density as well as the lucency around it. Breast and prostate stimulate an osteoblastic response in the host bone. It makes the host bone fight back. So we can get weird mixed changes, part lucent, part mixed. So those are weird. They just do that. This was a patient who complained of tooth mobility and had some soft tissue changes around the teeth that were mobile and vague, ill-defined lucency. And that one ended up being adenosquamous carcinoma from the lung. Can you tell by looking at it came from the lung? No. Is it a surprise? No. That's one of the ones that can go there. How would you describe this lesion radiographically? Lucent, opaque, or mixed, or other?
Lucent.
Part of it's lucent, part of it's mixed. Doesn't it kind of look ground glass?
Yeah.
Is this a small, medium, or large lesion? Medium? Small? Can't decide? Were you expecting that? It's big. Do you see any signs of malignancy clinically? The prominent blood vessels, the surface ulceration. Even though this may not look like a malignancy, this sure does. So, yeah. So that got biopsied. This one ended up being metastatic colon cancer. Yeah, so they can come from far away. So what is the prognosis for metastatic disease? Very poor. With the new biologics that are coming out that are targeting specific mutations with some of these diseases, We're starting to turn things around even for patients with metastatic disease. But even so, if we find a metastatic lesion in a patient, that's associated with a poor prognosis. They need to work with their physician. Do they always have a diagnosis of a primary cancer? Not always. Sometimes the metastatic lesion is the first sign. So these are patients that have to get worked up. This patient is going to get a biopsy. This patient in a general dentistry practice is going to go to the oral surgeon, get a biopsy, and then get referred in for medical care. But ignoring something like that, that would be pretty foolish. What else do I want to say about these? Breast cancer, number one thing that metastasizes to jaws. Sometimes does have a history of breast cancer years prior. Breast cancer is famous for late recurrence, late metastasis. Could be 10, 15, 20 years later when the patient thinks they're cured. And that's one of the sad things about breast cancer. So I think that's all I want to say, and I'll let you go, and I apologize for holding you over.
I have a quick question. For when we, like, on the quizzes and tests, do we specify, so let's say we see this, do we put metastatic tumor?
Metastatic carcinoma. Usually we just say metastatic carcinoma.
Okay, we don't have to say, like, due to, okay.
If you want to add to it because of the gender or something suspicious for breast or whatever, that's fine, but
Okay.
the most important thing is the metastatic.
Sounds good.
I have to stop my recording. Okay, we're good.
This is a picture of my sister's panorama.
Panorama. I like that.
Is it a panorama? No, I know it's not. She just